Thank you for joining us for Conversations and Cases in Oncology, updates in the treatment of early-stage non-small cell lung cancer, expert opinion. In this segment, we will be discussing neoadjuvant therapy in early-stage non-small cell lung cancer. I'm Jamie Chaft, an associate attending physician at Memorial Sloan Kettering Cancer Center and associate professor at Cornell. I'm joined today by my colleagues, experts in the field, Dr. Stephen Liu and Dr. Julie Brahmer. Welcome. So we're going to talk a bit today about my passion, neoadjuvant therapy in non-small cell lung cancer. And historically, it has always been neoadjuvant chemotherapy. And finally, after painstakingly long trials and efforts, we've seen some advances in the field, moving beyond what neoadjuvant chemotherapy can provide. So I think we know that neoadjuvant therapy has been the underdog in lung cancer for a really long time. When all of the adjuvant studies read out, the neoadjuvant efforts were closed, short of full accrual, and we're stuck with meta-analyses data. But all of the meta-analyses of chemo, cisplatin-based chemo for the most part, were comparable to adjuvant therapy with a hazard ratio of 0.85 or 0.86 and a 5% survival advantage at 5 years. And this is 5% greater than surgery alone. So real, but small advantage. So we continue to ask, what more can we do in the perioperative setting, and in this segment, the neoadjuvant setting specifically? And I'll start by asking some questions of my colleagues. We have other drugs, we have other technologies. Do you and your patient populations offer neoadjuvant chemoradiotherapy? What do they do at Hopkins?
So we have up till this point, we've done a lot of neoadjuvant chemotherapy and radiation for our patients with incidental N2 disease. But now based on Checkmate 816 with the data for N2 disease, we've been pushing our rad-onc colleagues that really neoadjuvant immunotherapy fits the bill here, and we can, I think, patients can get through the therapy much more easily, and certainly be able to not have to undergo radiation. I think in my mind, again, I'm not the surgeon, I think easier to resect at the time of surgery as well. But those are my thoughts. Steve?
Yeah, so for a long time, Georgetown really was a neoadjuvant chemoradiation group, and we that was really our standard for microscopic N2 disease. Our practice actually changed more with lung art. Our thought was for a mediastinal node positive N2, we were going to offer radiation afterwards, why not offer it before? And when lung art came negative, we really started to question that practice. And so it was really based more on those data that we decided to abandon the radiation in both the postoperative and the neoadjuvant setting and move just to neoadjuvant chemotherapy. And then certainly with the work that you and Dr. Ford and Dr. Brahmer had done, we were very eager to move immunotherapy in. And while my radiation colleagues are some of my best friends, I will say our surgeons weren't sad to see the radiation go.
Fair enough. And interesting, I didn't know how you would answer that question. You're in the 50% of a few years ago, that 50% of the NCCN institutions offered neoadjuvant chemoradiotherapy, but interestingly, there's never been a study that shows an advantage of neoadjuvant chemoradiotherapy over chemotherapy. All of them use outdated drugs and older radiotherapy techniques. So perhaps there's a role in some patient populations, but we don't know who those patients are. And I hope the rest of the field is moving as you are towards our newer agents. So you both mentioned immunotherapy. We can talk a little bit about the data. Julie and I, our institutions worked together on the very first study of neoadjuvant immunotherapy, and it was really a proof of principle study with just 2 doses of neoadjuvant PD-1 therapy. And we saw an unexpected pathologic regression in these unselected patients where the tumors of nearly half or 40% of patients were mostly dead at the time of surgery after just 2 doses of PD-1 therapy. This was pretty fascinating, and it really raises the question if there's something unique about that tumor being in the body at the time of exposure to checkpoint inhibitors. We've subsequently seen 2 large single-arm studies of neoadjuvant chemoimmunotherapy. And of course, there was concern, does the chemotherapy abrogate a durable immune response? But these studies showed such remarkable outcomes that they were almost unbelievable. In both the Nadim study out of Spain and a study using platinum taxane atezolizumab in multiple academic institutions in the US, we saw pathologic regression rates of complete responses anywhere from 30 to 50% in these studies. Now, those data certainly led to a lot of enthusiasm for enrollment in the randomized studies. And we were very hopeful that these randomized studies would be positive. And you've referred to the new standard of care, Julie, based on the data in N2 disease from the Checkmate 816 study. So we'll talk a little bit about that now. And we'll hope that the forthcoming data reports are not as confusing as we've seen in the adjuvant setting. But 816 is a study of neoadjuvant chemotherapy versus chemoimmunotherapy with nivolumab. And one of the, I think, beautiful things about 816 is it did allow carboplatin-based therapies. We know that in the adjuvant setting, nearly all therapies that have been robustly studied are cisplatin-based, yet our older patient populations can't tolerate cisplatin for the most part. Checkmate 816 was a randomized study, and the arms that have been reported are chemotherapy with or without 3 doses of nivolumab, so 3 cycles of chemotherapy. And the results are truly intriguing. The first results we saw were endpoints that were pathological and clinical, and these endpoints showed a 13-fold improvement in pathologic complete response. So at the time of surgery, the tumor had no residual cancer cells, both in the tumor and the resected lymph node. Now, 13-fold sounds really impressive, but the reality is that chemotherapy alone performed horribly, with only 2% of patients achieving a complete response. I think more impressive was the data on clinical outcomes in terms of resectability, in that there was a greater R0 resection rate, meaning negative margins, and fewer pneumonectomies, so more lung-sparing surgeries. Do you see in your institutions that you're being referred higher risk patients for induction chemoimmunotherapy than perhaps in the past based on these data? Julie?
I think both of us are seeing more patients referred in, though I think a lot of our colleagues in the community are also seeing a fair number of patients. I do think, in my mind, for patients that we want to make resectable, I'm not 100% sure that patients would now become resectable post chemotherapy and IO in the neoadjuvant setting. So I'm trying to restrict those patients that look upfront resectable, potentially with N2 disease, certainly based on the NADIM's data, and giving them the 3 cycles of chemotherapy and nivolumab. What about you, Stephen?
Yeah, same. We're seeing, Jamie, a lot of patients referred that are frankly just unresectable at the time. And the thought is that, now that we see these data, instead of giving chemoradiation and consolidation durvalumab, can we give some therapy to make them resectable? And that's not really what the data that you've generated and data you've discussed showed. And so we also do try to be fairly strict that decision is made up front, though I would have total equipoise with that study if it were one that you and Julie would write. We certainly would participate. But I agree with what was said, that generally some of the high-risk people who are being referred are simply not appropriate for surgery.
Right. It's a study that's been done in Switzerland. We've seen data in resectable 3B, the old 3B, not the new 3B, where patients were given neoadjuvant cisplatin and docetaxel at doses that we don't even consider in this country. But designing that study to really answer the question of conversion, can you convert an unresectable tumor to a resectable tumor, is really wrought with challenges, right? Because we have a very good standard of care option for those patients now with concurrent chemoradiotherapy. So I absolutely agree with you, making the surgeon, put it down in their note that this patient is resectable at the time of referral. And I've certainly asked for that clarification on multiple occasions. So I think there was a lot of excitement about that 816 data we've talked about already, but also there were many holdouts, and there were people holding out for event-free survival. We were, of course, fearful that postoperatively patients may have complications after being exposed to checkpoint inhibitors in the neoadjuvant setting, or that these 3 cycles perhaps weren't enough. I mean, historically, perioperative therapy has been 4 cycles of cisplatin, right? Not 3 cycles of carboplatin in some patients. And interestingly, the event-free survival data was really impressive, right, with a hazard ratio of 0.6. And when we looked at the subsets, which is curious to me, we see one of the subsets of greatest benefit was actually those who received carboplatin, not cisplatin. I'm curious why that is. Perhaps it was what was paired with it, but certainly eye-opening for what is our rapidly aging patient population in our lung cancer clinics. Do you think these event-free survival data are good enough? Have we really moved the bar to be giving preoperative therapy routinely?
I think they are. I think these numbers sort of were even better than I had expected. And the patients especially in the patients who achieve a path CR, those event-free survival curves are pretty much as flat as you could hope for. I think there's some room for those that don't achieve path CR, but I do think that it performed certainly well enough to become a new standard option.
Yeah. Julie, are your surgeons comfortable with operating after chemoimmunotherapy?
Oh, well, most of them are, but they do say it's definitely a different field of play, certainly after a patient's received immunotherapy. But, based on the data, there wasn't a significant increase in post-op mortality or even morbidity. So I do think that some of their hesitancy, I think, is laid to rest by the data.
Right. So we've seen interesting data in both stage 4 disease, obviously, and in the adjuvant setting where PD-L1 expression really plays a role in patient selection for these drugs. And similarly, there seemed to be a bit of a superior EFS advantage in patients who received neoadjuvant chemoimmunotherapy with PD-L1 positive tumors. Are you routinely testing your patients at diagnosis before preoperative therapy for PD-L1 expression?
We are not. So pretty much at our institution, the way our workflow is, it's usually endobronchial ultrasound. It's sort of a little bit smaller in terms of the amount of tissue we have. So we really try to funnel that in towards molecular testing, because if I do see a driver like an EGFR or an ALK, we will probably go a different route, hopefully a different clinical trial, but we'll probably avoid immunotherapy there. So I usually try to preserve the tissue for the molecular testing, because I think that right now, I don't know that the PD-L1 sways me strongly enough to withhold immunotherapy here.
Right.
Okay.
Go ahead. I think it's definitely interesting in trying to, again, get more out of a small amount of material and trying to figure out how to quickly get those mutation tests performed in order to, in my mind, not give the patients such as EGFR or ALK positive patients neoadjuvant chemo IO.
Yeah, interestingly different from the adjuvant setting where adjuvant immunotherapy is approved irrespective of driver status. The A16 study did exclude EGFR and ALK-driven tumors, so having that data is fairly essential now. Let's just think about a theoretical patient. So I had a patient in my clinic a few weeks ago, somewhere between 65 and 70, very fit, was jogging and had a screening scan, which we know is not all that common, but we're happy when we do see them. Unfortunately, he had some involved lymph nodes even at the time of screening, a 1.6 centimeter paratracheal node, and EBUS confirmed it to be a squamous cell carcinoma. His contralateral nodes were negative, and he was referred to me for preoperative therapy, but he told me that there was no role for surgery in his disease. So how hard do you twist his arm? So consider it a single station N2, medically fit and technically operable. Stephen, do you try to talk him into preoperative chemo IO?
I probably do. I really do think there's a benefit there. And I think that when they say there's no role for surgery, I would probably just start by trying to understand what that means, if there are some fears or concerns about surgery, because I truly believe that surgery is going to give you the greatest chance of cure in this setting. So while we share these decisions with our patients, this is a setting where I really try to stress the benefits here. And I think that neoadjuvant chemoimmunotherapy and surgery is a wonderful option in this case.
Julie, are there any patients you don't want to offer neoadjuvant chemoimmunotherapy to?
Well, I think, there are those super special patient populations, patients who have active autoimmune diseases that are requiring therapy, or, certainly patients where they're kind of on the borderline of resectability anyway. Obviously, maybe if they're bulky N2, I'm not going to push, but certainly someone with single agent and single station N2, I'd sit down and go over the Nadim-2 study, and go and show them some of the slides and, some of the pictures that they showed, which were quite remarkable.
They were. Well, thank you both for your input, and thank you all for joining us on this segment on neoadjuvant therapy in early-stage non-small cell lung cancer. Please be sure to click on the activity landing page to claim your AMA, ANCC, or ACPE credit, and to access other topics in this segment, such as adjuvant therapy in early-stage non-small cell lung cancer and therapy in special populations. Thanks.